MRV, they should see the MMR.
I want to clarify this.
And that's the end of my updates. I'll now take questions.
I want to make a clarification.
Presentation is now open for questions.
These are recommendations
Ms. Fata?
by the CDC
Just a point of
only.
clarification. I know that we have already
It's up to the states
COVID-19 for children.
if they'll push these recommendations. Which state do you live in?
Okay for us to include that in the
I just want to clarify that.
schedule if it's a EUA interim recommendation.
Yes, before we brought this to the work group, we had a conversation about this with our Office of General Counsel, and we're told that it was okay to add it to the schedule.
That's all I want to do. I want to clarify that these are recommendations.
Can you go to the one on polio? It was age 18. About
I'm not sure
5 slides back.
What your state will recommend.
39. Thanks.
But yeah, I want to put this on full screen without me all the way because
it says adolescents age 18 years. So is it only for an 18-year-old?
Let me see if I can correct that.
It's only the current polio policy has a routine recommendation
I think that's the way you do it.
Age 17 years. So beginning at age 18 years,
you're visible.
Vaccination is not recommended, and this policy is from 2000. So for persons who are age 18 years and older, polio vaccine is recommended if they have increased risk of exposure. So in the child and adolescent schedule, which is up to 18 years, this only applies to adolescents age 18 years, and those 19 years and older will be reflected in the adult schedule.
Okay, thank you for the clarification.
Any additional questions? Actually, I have one question on slide 37. When you replacing for the pneumococcal conjugate vaccines, my simple question is, why did we delete chronic liver disease? Is that no longer a risk factor for anybody?
Miwako can help me here, but my understanding is that it was in the last policy note, it was added in error for the children and adolescents, and when the new policy note for use of PCV15 was written, that error was corrected. She's asking why we deleted chronic liver disease and alcoholism from the child and adolescent schedule.
Just for clarification, I think alcoholism makes sense. I think chronic liver disease, we definitely see children with chronic liver disease who need liver transplants. Yes, thank you for that question. So what happened in the past was chronic liver disease was never part of the table that lists the risk conditions for the pediatric table, and then that's reflected in the current MMWR R&R that was published in 2010. And when there was a vote on use of PCV13 in children with underlying conditions, immunocompromised conditions, age 6 to 18 years, and that was back in 2013. When the MMWR was published, the table that was included in the published MMWR was reflected the conditions that's used in the adult group. So there's always been this confusion because it was never the intent to change the table. It was not something that was presented to ACIP, but then when the MMWR was published, the table for that age group was switched over. So with the update, with the recent MMWR that was published for the PCV15 recommendation, we tried to just address that previous confusion that happened. And maybe I'll just ask if the pneumococcal work group will consider that in the future.
I would like to clarify, we're going to be addressing PCV20, and this would be a very easy way to include that in that conversation.
Thank you so much. Any other clarifying questions? Oh, Dr. Daly.
Yeah, so I'd like to make a couple sort of overarching comments, and this is in response to public comment that we've received. So, is that okay, Dr. Lee? Do we have time for that? Okay. So, we've received comments from the public that are concerned about adding COVID-19 to the routine schedule, to the routine childhood schedule. And I just want to address that directly. This doesn't represent new recommendations. This represents sort of a summary of existing recommendations. But I will acknowledge, I appreciate that there is symbolism in adding COVID-19 to the childhood immunization schedule. And that symbolism is that we view this as routine and that we view this as COVID is here to stay. And so when I think about the routine immunization schedule as a practicing pediatrician, I think about it as an opportunity in my patients to prevent serious disease and death. That's what I view that as. And if something is added to the schedule, it's because I feel like the benefits continue to strongly outweigh the risks. And so I just want to make those points. The other point I will make is that this does not constitute a mandate. But there are mandates, but those are really state Board of Health largely decisions, and this doesn't represent a mandate. But then I appreciate that if parents are concerned about COVID-19 vaccines, then they're concerned that this could be turned into a mandate. And again, I would want to turn that conversation in a different direction. I've had parents who come in my office and I say, oh, what are you here for? And they say, well, we're here for vaccines so that our kids can go to school. And I've said, okay, I understand that, but really I'm not vaccinating so you can go to school. I'm vaccinating because I want to prevent serious disease and death in your kids. And the fact that there's a school immunization requirement helps because it brought you into the office, but that's not my goal. My goal is to prevent serious disease. So those are overarching comments. I just want to acknowledge that we heard the public's concern about this in the public comments, but just to reiterate that the reason things are added to the schedule is that we feel like the benefits strongly outweigh the risks, and these are opportunities for disease prevention, but we acknowledge that there's concern on the part of the parents. I guess the last point I'll make is we just need to continue to do better at communicating why we think the benefits strongly outweigh the risks. Thank you.
Thank you, Dr. Daly. I don't see any additional hands raised. Oh, Dr. Shaw, please go ahead.
I'd like to underscore the importance of Dr. Daly's comments, and I wanted to add one or two other pieces of clarification. The vote and the discussion around the addition of COVID-19 vaccines to the recommended immunization schedule is separate and distinct from yesterday's vote in support of a resolution to add COVID-19 to the Vaccines for Children program schedule at the point that the vaccines become commercialized. Yesterday's vote, in effect, was a resolution about the coverage of the vaccine for and underinsured children, not a discussion of what pediatricians ought to be doing in an office setting. This discussion today around adding the COVID-19 vaccine to the recommended childhood immunization schedule does not constitute a requirement that any child receive the vaccine. That decision remains where it did before. This is rather a codification of a pre-existing recommendation. We recognize that there is concern around this, but moving COVID-19 to the recommended immunization schedule does not impact what vaccines are required for school entrance, if any. Indeed, there are vaccines that are on the schedule right now that are not required for school attendance in many jurisdictions, such as seasonal influenza. Local control matters, and we honor that. The decision around school entrance for vaccines rests where it did before, which is with the state level, the county level, and at the municipal level, if it exists at all. They are the arbiters of what vaccines are required, if any, for school entry. This discussion does not change that. Thank you.
Thank you, Dr. Shaw. And with those comments, I think what I'd like to do is move on to the next session by Dr. Neil Murthy on the 2023 adult schedule revisions.
They're trying to get the
Technological issues. Sorry about that.
your computer is moving.
Oh, okay, it's moving. Yeah. Thank you so much, Dr. Lee, and good morning, everyone. My name is Lieutenant Commander Neil Murthy, and along with Dr. Patricia Wody, I serve as the co-lead for the Combined Immunization Schedules Work Group. And this morning, I'm very grateful to have the opportunity to present to you all the proposed updates to the 2023 Adult Immunization Schedule. This is an overview of what I'll be covering in the next couple of slides. I'll present only substantive changes to the 2023 Adult Schedule. Minor grammatical or formatting edits that are meant to improve clarity in the language will not be presented. I'll begin this discussion by walking through the proposed edits to the cover page and tables, followed by discussion of the proposed vaccine-specific changes in the notes section, and finish with a brief discussion of the proposed changes to the appendix section, which lists the contraindications and precautions to all vaccines that are recommended in the schedule. Let's start with the cover page. There are 6 main changes on the cover page. The first edit is to the upper right-hand corner of the cover page, where we have added the American Pharmacists Association as a partner organization approving the adult schedule. The next couple of edits are in the list of adult vaccines. You'll notice that for the first time, we have added COVID-19 vaccines to this list of recommended vaccines. The first abbreviation shown here refers to the monovalent mRNA vaccines. The second abbreviation refers to the bivalent mRNA vaccines. And the last abbreviation on this list refers to the monovalent protein subunit vaccine. In the Hep B row, we have now added PreHevbrio to this list. Similarly, in the MMR row, we have added Priorix to this list. Compared to the 2022 schedule, you will notice that we have combined the pneumococcal conjugate vaccines, PCV15 and PCV20, into one row in this table. And finally, under the injury claims section, we have included information here about COVID-19 vaccines and the Countermeasures Injury Compensation Program. We'll now turn to the changes recommended in Table 1 that outlines the age-based recommendations for adult vaccines. Table 1 has 3 proposed edits. The first edit is the addition of the COVID-19 vaccine row. You'll see here that the entire row is yellow, indicating that COVID-19 vaccination is recommended for adults of all age groups. Guidance regarding the COVID-19 primary series and booster doses is provided in the overlaying text. The second edit is to the MMR row, where overlaying text has been added to the greater than or equal to 65 years of age column. We now refer providers to the notes section for vaccination considerations for healthcare personnel who are older than 65 years of age. And the final edit is to the hepatitis A row, where the overlaying text now states 2, 3, or 4 doses, depending on vaccines, to include the 4-dose accelerated twin risk schedule that can be used for hepatitis A vaccination. Let us now turn to Table 2, which is the medical indications table. Compared to the 2022 schedule, there's only one major change to Table 2, and that is that COVID-19 has been added as a row to this table. The HIV and immunocompromised conditions columns has a C notes as an overlaying text, since such patients may have different primary series requirements and may have additional considerations for pre-exposure prophylaxis to complement COVID-19 vaccination. We'll now turn to changes proposed in the notes section of the adult immunization schedule. In each of the subsequent slides, I'll walk through the notes section and explain the proposed changes in each of the vaccine-specific sections. For your reference, the page number of the notes section can be found in the upper right-hand corner. And we'll begin our discussion with the addition of the COVID-19 section on the first page of the notes section. You'll notice that in the 2023 schedule, COVID-19 is now formally incorporated to the schedules and is no longer in a special call-out box like how it was in previous years. The COVID-19 section begins with the routine vaccination guidance portion that describes the primary series for the mRNA vaccines and for the protein subunit vaccine for the general population. Because guidance on booster dose recommendations may change based on evolving data, providers are encouraged to review the latest booster dose recommendations at the website presented here. The Special Situations section starts off with a brief description of the recommended primary series for persons who are moderately or severely immunocompromised. Again, a hyperlink is provided here for providers to refer to the booster dose recommendations for persons who are moderately or severely immunocompromised. The last bullet in this section reminds providers to consider pre-exposure prophylaxis in addition to COVID-19 vaccination for persons who are moderately or severely immunocompromised. And the COVID-19 vaccination section ends with a note referring providers to additional resources on COVID-19 schedules and emergency use authorization indications for these vaccines. We'll now move on to the hepatitis B section. As you're aware, hepatitis B vaccination is routinely recommended for all adults 19 through 59 years of age. The descriptions of the 2, 3, and 4 dose series are provided here in the routine vaccination section. Compared to last year's schedule, these descriptions have been slightly revised. Any reference to the 4 dose series for persons on hemodialysis has been moved to the special situations section, which we'll see later in this Hep B section. PreHevbrio was also added to the description of the 3 dose series. And the note at the end of this section states that Heplisav-B and PreHevbrio are not recommended in pregnancy due to a lack of safety data in pregnant women. The hepatitis B section continues on to the second page of the notes. 2 bullets have now been added here describing the recommendations for persons 60 years of age and older. The first bullet states that anyone aged 60 years or older with known risk factors for hepatitis B virus infection should complete a Hep B vaccine series. And the second bullet states that anyone aged 60 years or older without known risk factors for hepatitis B virus infection may complete a Hep B vaccine series. Risk factors for Hep B virus infection are then listed. Minor edits were made in this section to improve clarity in the language. The hepatitis B notes section ends with a special situations section describing the vaccination regimen for patients on hemodialysis. Moving on now to influenza. A sub-bullet was added to the routine vaccination section for persons who are 65 years of age or older. This sub-bullet states that any one of the quadrivalent high-dose inactivated influenza vaccine, quadrivalent recombinant influenza vaccine, or quadrivalent adjuvanted inactivated influenza vaccine is preferred. If none of these 3 vaccines are available, then any other age-appropriate influenza vaccine should be used. We have added the hyperlink to the 2022-2023 influenza recommendations, and we have a bullet for the 2023-2024 influenza recommendations here as well. In the special situations section, we have modified the bullet describing guidance for persons with an egg allergy who experienced any other symptoms other than hives. This bullet now reads that any influenza vaccine appropriate for age and health status may be administered to such patients. If using egg-based IIV4 or LAIV4, administer in a medical setting under supervision of healthcare providers who can recognize and manage severe allergic reactions. We have added a bullet here in the special situations section describing the guidance for persons who are close contacts of patients who are severely immunocompromised. This bullet states that close contacts of severely immunosuppressed patients should not receive live attenuated influenza vaccine. If LAIV is used, they should avoid contact with or caring for such immunosuppressed persons for 7 days after vaccination. We'll now move on to the third page of the notes section, where we begin with the MMR section. The MMR section has only one major addition this year. A bullet has been added referring providers to the guidance that describes administering an additional dose of MMR in the context of a mumps outbreak setting. Finally, because I had mentioned the change in the MMR row in Table 1 earlier in this presentation, I wanted to just mention here that you may consider MMR vaccination for healthcare providers born before 1957 who do not have any evidence of immunity to measles, mumps, or rubella. This is why the overlaying text was added to the MMR row back in Table 1. We'll now move on to the meningococcal section. The only change to the meningococcal section this year is the addition of the guidance highlighted in yellow in this slide. This guidance describes that if the third dose of Tremenba is administered earlier than 4 months after the second dose, a fourth dose should be administered at least 4 months after the third dose. The fourth page of the notes section begins with the pneumococcal vaccination section. Please note that this pneumococcal section does not incorporate today's ACIP vote. Today's vote will be incorporated into this note section as soon as possible. A bullet has been added to both the routine vaccination and special situations sections, referring providers to the CDC app that providers can use as a resource to help determine a patient's pneumococcal vaccination needs. In light of the ongoing polio response that started this summer, we have also included a new polio section to the notes this year. Although we do state in the routine vaccination section that routine poliovirus vaccination of adults residing in the United States is not necessary, we do provide in the special situations section vaccine recommendations for adults who are at increased risk of exposure to poliovirus. Adults who have no evidence of a complete polio vaccination series should complete a 3-dose series, while adults who have evidence of completing a polio vaccination series may receive a 1 lifetime booster of IPV. Detailed information about these recommendations can be found at the hyperlink presented here. The last section on page 4 of the notes is the Tdap section. Here, minor edits were made in the guidance listed under the special situations section to improve clarity in the language. And this language now states that for persons who previously did not receive the primary vaccination series for tetanus, diphtheria, or pertussis, they should receive 1 dose of Tdap followed by 1 dose of TD or Tdap at least 4 weeks later, and a third dose of TD or Tdap 6 to 12 months later. We'll now finish with the final page of the notes section. A few changes were made to the zoster section this year. A note was added at the end of the routine vaccination section, providing some background on serologic evidence of prior varicella. This note reads, serologic evidence of prior varicella is not necessary for zoster vaccination. However, if serologic evidence of varicella susceptibility becomes available, providers should follow ACIP guidelines for varicella vaccination first. RZV is not indicated for the prevention of varicella, and there are limited data on the use of RZV in persons without a history of varicella infection or varicella vaccination. In the special situations section, the language in the immunocompromising conditions bullet has changed. This bullet now clarifies that immunocompromising conditions include persons living with HIV regardless of CD4 count. Additionally, the zoster vaccine regimen is provided here, along with the hyperlink for providers to learn more. Finally, a note has been added at the end of the special situations section to provide some background for persons with immunocompromising conditions who do not have a documented history of prior varicella infection, varicella vaccination, or prior herpes zoster. This note reads, if there is no documented history of varicella infection, varicella vaccination, or prior history of herpes zoster, providers should refer to the clinical considerations for the use of RZV in immunocompromised adults aged greater than or equal to 19 years, and the ACIP varicella vaccine recommendations for further guidance. And that resource is hyperlinked here. Let's now turn to the appendix section that lists all of the contraindications and precautions to each of the adult vaccines. To see changes in the appendix section, let's zoom in and look at the subsections on this appendix in detail. The first change is to the header of the appendix table, where we have changed the header of the contraindications column to contraindicated or not recommended. And just like last year's appendix, the first page of the appendix lists all of the contraindications and precautions to the influenza vaccines. You will notice that the precautions column no longer lists having an egg allergy in the precautions column, since any influenza vaccine appropriate for age and health status may be administered to persons with an egg allergy. The second page of the appendix lists all of the contraindications and precautions to all of the non-influenza vaccines. Again, let's zoom in here to see the edits to the second page of the appendix. In the Hep B row, the language regarding pregnancy has changed. The language now reads that Heplisav-B and Prehevbrio are not recommended due to the lack of safety data in pregnant persons. Use other hepatitis B vaccines if Hep B is indicated. The language for the pregnancy row, the language for pregnancy in the HPV row has also changed. The language now states pregnancy HPV vaccination not recommended. With that, I'd like to thank you all so much for your attention, and I'll pause here for any questions. Thank you all so much.
Thank you, Dr. Murthy. This presentation is now open for questions. I actually have two for you. One is on the slide that, oh my goodness. Actually, I'm going to see if anybody else has questions because I want to find it for you. Oh, no. Sorry. That was a lot of slides. On slide, I think it's 65 in our PDF, Table 1, Hepatitis A.
Yes.
My question is really, it says 2, 3, or 4 doses depending on vaccine, and I'm assuming that's because it's tied to the hepatitis B vaccine, but are we really recommending 4 doses of hepatitis A vaccine?
This is just to accommodate for the dosing regimen if you use Twinrix. So that would also confer protection with hepatitis A. So that was just to be comprehensive and to include that regimen. That was the reason for that change.
Okay. It might, like, I think from a recommendation standpoint, to me, it would be clearer if we said, 2 or 3, and then, but 4 is acceptable kind of a thing. Because I don't believe we have a recommendation for 4. We have a recommendation for the combined vaccine.
Okay. Yeah.
Just to consider.
Okay.
And then my other question was, since COVID vaccines are on the schedule, should we also include them in the contraindications precautions section? Did I miss it? I apologize if I did.
Yes, we discussed adding that in the table in the appendix, but in discussions with vaccine safety, they are reviewing those contraindications and precautions, and there might be an update before the 2024 schedule. So we decided not to make a change at this time.
Any other questions, Dr. Cotton?
I have a question on table 2 with the new COVID. So it says see notes for immunocompromised and for various HIV populations, but then it's blank to the right of that. And I guess I would suggest considering putting in the same language as table 1 where it says 2 or 3 dose primary series and booster, see notes, but just for clarification. Seems like that was sort of left off. I can show you.
Yeah,
I can
that
show
would be
you
helpful.
manually too. I just want a copy and paste.
Thank you, Dr. Cotton. Yes.
Thank you.
Dr. Goldman?
Thank you. Excellent presentation. I have a question on the notes section for hepatitis B. For 60 and above, where it says may receive. For clarification, I think in the past it said anyone seeking protection from hepatitis B. Just wondering if we can clear up that language a bit, because it's very vague when it says they may receive it, but why would they receive it after age 60? In the past it's been for seeking protection, so I don't know if we can just clarify that a little for those who don't have the absolute indication of risk versus age. And that's my only concern with that.
Thank you, Dr. Goldman. We can talk to the hepatitis B folks here about that suggestion.
don't see any additional hands raised. Just to go back to the COVID-19 comment, I think, well, I would appreciate it if recognizing there's constantly dynamic changes that happen, if we could link back to the, at least the clinical guidance or something in the schedule, just so people can look it up and link back to the original.
So there is a link on in a box at the very top of the appendix that links providers to the contraindications, precautions for COVID-19 vaccination.
Okay.
But I mean, once we hope to incorporate that formally as a row in that appendix once we're able to.
Okay, thank you very much. Okay, I can't believe this, but we're not only running out of time, we are a little bit early. Are there any additional questions, clarifications? I'll open up to our liaisons. Okay. Well, I'm going to ask that we reconvene at, we didn't finish, apologies. Dr. Paling.
I would like to make a motion to approve this with the recommendation, with the considerations that have been discussed. Thank you.
Thank you. I got too excited. Do I have a second? I'm going to go with Dr. Sanchez. Dr. Sanchez.
I'd like to second the motion.
Thank you. Is there a vote language that we can just clarify and put up about the adult and childhood immunization schedules, please? We're going to pause on this. We are going to take a 5-minute break, and I'm going to ask people to be here at 25 minutes after the hour, and we'll come back to this. Thank you. Oh, you got it? Okay. I take it back. Don't leave. Here's the language for the vote, just to approve the recommended child and adolescent immunization schedule, US 2023, and the recommended adult immunization schedule, US 2023. So Dr. Paling moved, Dr. Sanchez seconded. Any concerns? Okay, terrific. We have this motion on the table for a vote later today, and we will now break until 25 minutes after the hour. Thank you, everyone.
To the very end, in the corner. Yeah.
Okay, so you have your notes here. We got. All right.
You're not on mute. No, we're not on mute.
All right. I want to clarify this a little bit. The CDC is changing the wording, and they're saying that these are recommendations for the states. You know, states like New York and California, states like that, will probably most likely go by these recommendations. And what I'm trying to do is wait this out. I mean, it's up to y'all. You're the viewer. It's up to everyone if you want to stay or go. I don't know how long this could take. This could take all day. I don't know. I mean, really, I don't want to waste your time or anything, but it's very important, you know, to figure out what they're up to. Sorry about this. But yeah, these recommendations, say you're in the hospital in California, and the CDC hands down these recommendations. Say your family they're not able to contact anyone or something like that. I mean, based on situations, and states will have the right to, you know, to do as they wish.
Thank you, everyone. We'll reconvene in exactly 1 minute.
So these practices, like on the screen and all that, my grandchildren are still here, y'all. Sorry about any background noise. I was gonna play some music. So it's up to you all. I don't want to. I even need to do a few things today. So yeah, I don't want to waste nobody's time, but I'm going to be paying attention to this the whole time. I'm going to keep my phone in my pocket whenever I'm outside or doing whatever I need to do.
Thank you, everybody. We're going to go ahead and get started with the next session today, which is on respiratory syncytial virus vaccines in older adults. And Dr. Camille Cotton is our work group chair for this particular work group. Dr. Cotton?
Good morning, everyone. So we will initiate discussion of the adult respiratory syncytial virus vaccine. Next slide, please. Next slide, please. We are very lucky to have a wonderful adult RSV work group. As you can see, there are various ACIP members, ex officio members. We have a wonderful CDC lead, Dr. Michael Melgar. We have a host of consultants and liaisons, and we are greatly appreciative to everyone for their wonderful input and excellent discussions during the working group. Next slide, please. We also have a whole host of CDC contributors who really have been incredibly helpful developing this knowledge on this vaccine. Next slide, please. And so just to recap, last February, that should say 2022, we had the introduction to the adult RSV working group. We had orientation to the multiple vaccine products in development to prevent RSV disease in adults. We had an overview of RSV virology and immunology, and also an introduction to the seasonality and burden of RSV disease in the United States. Next slide, please. Recent working group discussions included selection of efficacy and safety outcomes for the review of RSV vaccines for older adults. And we were also fortunate to have two presentations. The first was from GSK on the safety and efficacy of adjuvanted RSV pre-F3 vaccine in adults 60 years and older, and then a presentation from Pfizer on the safety and efficacy of bivalent RSV pre-F vaccine in adults 60 years and older. In addition, we have had some work group discussions regarding potential barriers to uptake of a novel RSV vaccine for older adults. And several of the things that we discussed included a lack of patient and provider awareness of the importance of RSV as a pathogen in older adults. And we think that will actually be something that we will need to do a lot more education and enhance knowledge and understanding of the importance of this, and that it is in some seasons actually quite similar to influenza, but many providers may not be aware of that overall impact. Furthermore, we have some concerns about vaccine fatigue, given that there have been multiple COVID-19 boosters. We are also expanding pneumococcal vaccines and the ongoing need for influenza vaccines, et cetera, et cetera. So there may just be some vaccine fatigue out there. In addition, there is some increasing complexity of the adult immunization schedule, although we greatly appreciate the work that was just presented at decreasing the complexity or simplifying it, but nonetheless, with each rendition, it is somewhat there's more volume in the adult immunization schedule. And then we also have some concerns about potential either public or provider hesitancy to co-administer RSV vaccine with other indicated vaccines, which may make the vaccine rollout somewhat complicated. So the agenda today is that we will have two presentations, the first from GSK, the second from Pfizer, and then Dr. Michael Melgar will present our work group considerations. Thank you.
Thank you, Dr. Cotton. We'll move on to the next presentation by Dr. Rizkala on GSK safety and efficacy.
Thank you so much. Just checking that you can hear me okay?
Yes, we can hear you. Thank you very much.
Thank you. Well, firstly, thank you to the ACIP for the opportunity today to present the results from the GSK RSV older adult vaccine clinical development program. Just by way of, we can't see the slides. If you're able to recall those, perfect, thank you. Just by way of introduction, my name is Bishore Rizkala and I'm the Global Medical Lead for our RSV program. If we can have the next slide, please. Now, the journey to a viable vaccine that addresses the significant burden of disease associated with RSV in adults 60 years of age and older and those with underlying comorbidity has been multiple decades long. It's really with great appreciation and thanks to all of the study participants, all of the site staff, study investigators, the GSK scientists, our R&D organisation that I'm able to present these positive results to the ACIP today on their behalf. Next slide, please. Today I'll present key results from 3 of our phase 3 studies. Firstly, I will share results from our immunogenicity and immune persistence study, which demonstrate the robust and persistent humoral and cellular immune response following a single dose of the vaccine. Then I'll present results from our pivotal efficacy study, which demonstrates the high and consistent efficacy of the vaccine candidate across the full spectrum of RSV disease, regardless of RSV-A or RSV-B subtypes. This study also demonstrates the vaccine is well tolerated with a favorable safety profile. I will then present immunogenicity results from our RSV and flu QIV co-administration study, which supports the co-administration of these two vaccines. Next slide, please. To begin, I will review the final formulation of the vaccine selected and used in our phase 3 program. Our vaccine is an antigen adjuvant combination that is designed to induce both a robust humoral and cellular-mediated immune response to help protect older adults and those with underlying comorbidity. Our vaccine targets the RSV F protein and is engineered to maintain the pre-fusion conformation of this protein. 120 micrograms of the RSV pre-F3 antigen is combined with our ASO1E adjuvant system to help boost the RSV CD4 T-cell response in older adults. This is the same adjuvant system that's used in our GSK shingles vaccine. However, the ASO1E that is used in our RSV vaccine contains half the dose of adjuvant. Next slide, please. Moving now from our formulation to the immune response elicited by our vaccine, I will present results from our immunogenicity and immune persistence study, Study 004. Next slide, please. As a summary of the design of the study, this is an open-label study that evaluates the immunogenicity, safety, reactogenicity, and persistence of the immune response following a single dose of the vaccine in adults 60 years and older. This study evaluates the immune response of varying vaccination schedules as denoted by the three arms that you can see on the slide. The study is ongoing, and today I will present data 12 months following initial vaccination. Next slide, please. This slide summarizes the immune response from varying perspective 12 months following the administration of a single dose of our vaccine. The two panels on the left describe the functional antibody responses with RSV-A NAb titers on the very left, RSV-B NAb titers in the middle, and looking specifically at the RSV polyfunctional CD4 T-cell response on the very right. There are three data sets in each of the panels which denote the immune response by different age strata. So those that are 60 to 69 years of age, those that are 70 to 79 years of age, and those 80 years of age and older. The vaccine induces a robust humoral and polyfunctional CD4 T-cell response as seen by the peak 30 days following vaccination. This immune response is sustained over the 360 days following a single dose of the vaccine to levels well above those pre-vaccination in all the age groups. This data supports that the vaccine is able to induce a robust and persistent immune response consistently across the broad spectrum of age in this older adult population. Next slide, please. Moving now from immunogenicity to efficacy, I'll take you through the results of our RSV 006 study. Next slide, please. Our ongoing pivotal efficacy study will evaluate the efficacy and safety of our vaccine over the course of 3 RSV seasons. Today, I'll present data following the first RSV season, as you can see denoted on the slide with current analysis. Approximately 25,000 study participants aged 60 years of age and older were recruited across 17 countries. Participants were 1-to-1 randomized to receive either an RSV pre-F3 vaccine or to receive placebo. The primary endpoint of the study is to demonstrate the efficacy of a single dose of our RSV vaccine in the prevention of RSV-associated lower respiratory tract disease in this first RSV season. Through the subsequent 2 seasons of the study, we'll be also able to demonstrate the efficacy of a single dose of our vaccine over the 3 RSV seasons, but also to be able to demonstrate the efficacy of our vaccine when administered annually. Lower respiratory tract disease in our study is defined as a participant that experiences at least 2 lower respiratory signs or symptoms, of which at least 1 must be a lower respiratory sign, or a participant that experiences at least 3 lower respiratory symptoms. All cases of RSV-associated lower respiratory tract disease were adjudicated by an independent external adjudication committee. Next slide, please. The demographic characteristics of participants recruited are representative of the older adult population. On the left, you can see the demography of the overall population, and in the box in blue on the right, you can see the demographics from the US perspective. The subjects recruited from the US represent 28% of the overall study population. Sites across 23 states and 8 human and health service regions recruited approximately 7,000 study participants. One important detail in the bottom of the slide is that participants with a medically stable chronic condition could participate in the study. Approximately 39% of the overall population had at least one pre-existing comorbidity of interest. What this means is a comorbidity that is known to increase the risk of severe RSV disease. So those that have underlying COPD, asthma, congestive heart failure, diabetes, advanced renal or liver disease make up this 39% proportion. Next slide, please. Moving now to the primary endpoint, and it's a real privilege on behalf of my GSK colleagues to present to the ACIP for the first time an RSV vaccine for older adults that has met its primary endpoint through a phase 3 program. Our vaccine demonstrated an efficacy of 82.6% in the prevention of RSV-associated lower respiratory tract disease. There is great confidence around this point estimate, with the lower bound of the confidence interval being well above the pre-specified criteria for success that has been agreed with regulatory authorities. Next slide, please. Continuing from the primary endpoint, we're also able to observe consistently high vaccine efficacy across the full spectrum of RSV disease. Specifically, we observed efficacy of 71.7% in the prevention of RSV-associated acute respiratory illness. This endpoint really casts a wide net to capture broadly upper and lower respiratory symptomatic RSV cases. This is an important result in the context of the millions of symptomatic cases experienced by older adults annually as presented by the CDC at the June ACIP meeting. Moving to the more severe end of the disease spectrum, we observed very high vaccine efficacy of 94.1% in the prevention of severe RSV-associated lower respiratory tract disease. Although we observed a lower frequency of hospitalizations with 2 cases in the first season, this can be expected due to several reasons. The first season of this ongoing study took place during the COVID-19 pandemic. This is a period when adults enrolled were commonly practicing social distancing, wearing masks, and investigators worldwide reported declines in hospitalizations due to non-COVID respiratory infections. Additionally, this is in the context of the clinical trial setting where there is close follow-up and protocol-defined medical attendance visits. We will continue to collect data to demonstrate the impact on hospitalization and other patient-reported outcomes over the upcoming seasons of the study. Importantly, however, consistently high efficacy of this vaccine across the full spectrum of RSV disease has the potential to deliver clinically meaningful impact on the significant annual burden of RSV disease in older adults. Next slide, please. The high vaccine efficacy against RSV-associated lower respiratory tract disease was observed over the 6.7 months follow-up period. As you can see in this cumulative incidence curve, there is clear separation between the RSV and placebo groups very early, which is sustained over the duration of the follow-up period. This supports the efficacy of our vaccine candidate over the course of an entire RSV season. Next slide, please. Looking now at efficacy in the more vulnerable subgroups, we observed high and consistent efficacy in these at-risk populations, with an efficacy of 92.9% in the prevention of RSV-associated lower respiratory tract disease in the pre-frail population, an efficacy of 93.8% in those with advancing age 70 to 79 years of age, an efficacy of 94.6% in those with pre-existing comorbidities of interest, and these are the comorbidities that are known to increase the risk of severe RSV-associated disease. In the bottom, you can see a call-out, which is important. So due to too few cases being observed in adults aged 80 years and older and those that are considered frail, we are unable to conclude vaccine efficacy in these subgroups. In this regard, it is important to evaluate the immune response in these specific subgroups. Next slide, please. And the vaccine demonstrates this high efficacy consistently, regardless of RSV-A or RSV-B subtype. Next slide, please. Transitioning now to safety. The study evaluated solicited adverse events following vaccination through the use of daily diary cards in a subset of study participants. This graph shows the local and systemic events for the 4 days following vaccination by event severity. So grade 1 events are shown in blue, grade 2 events are shown in orange, and grade 3 events in yellow. The most frequent local event was pain. The most frequent systemic event was fatigue. Most of these events were mild to moderate in severity, with very low frequency of grade 3 events observed following vaccination. The events were transient, with the median duration of the event subsiding between 1 to 2 days. Next slide, please. Unsolicited adverse events within 30 days in all participants are shown on the left. Most of the events were mild to moderate in severity, with a low frequency of grade 3 events seen within 30 days of vaccination. This is the largest and only placebo-controlled study in our phase 3 program, with approximately 25,000 study participants. The rate of SAEs, fatal SAEs, or potential immune-mediated diseases were balanced between the two arms 6 months following vaccination. Of note, there was a single case of GBS observed in a participant in the open-label immunogenicity study that I presented earlier, who has since recovered. The association was temporal in nature. However, with the evidence available, we cannot confirm the diagnosis or exclude an alternative etiology. Importantly, the Independent Data Monitoring Committee overseeing this efficacy study have not identified any safety concerns during the regular reviews of unblinded safety data. Next slide, please. Moving now to co-administration of our RSV vaccine with seasonal influenza vaccines. This is really an important feature in the context of the overlapping seasonality of RSV and influenza. This may be an important feature to support programmatic flexibility and implementation of RSV vaccination potentially in the future. The study looks specifically at co-administration of our RSV vaccine with inactivated quadrivalent influenza vaccine. Next slide, please. The primary endpoint of the study is the non-inferiority of the functional immune response of the vaccines when co-administered versus administration of either vaccine alone. A GMT ratio of 1.5 was set as the criteria for success for non-inferiority. The primary endpoint was met with all influenza antigen HI titers and RSV-A and RSV-B lab responses not exceeding the GMT ratio 1 month after vaccination. This supports that our vaccine can be co-administered with inactivated quadrivalent influenza vaccine without immune interference of either vaccine. In light of the ACIP flu recommendations that were made in June for older adults, We're also conducting 2 additional co-administration studies with high-dose and adjuvanted flu vaccines, and we'll present these data as they become available. Next slide, please. So to conclude, the GSK RSV vaccine candidate for adults aged 60 years and older provides a high and consistent efficacy across the full spectrum of RSV disease, regardless of RSV-A or RSV-B subtypes. The vaccine induces a robust and persistent immune response consistently across the broad spectrum of age in this older adult population. Supporting programmatic and implementation flexibility, the vaccine can be co-administered with inactivated quadrivalent influenza vaccines. The vaccine was well tolerated with a favorable safety profile. So really, to conclude and bring this all together, in the context of the significant annual burden of disease in older adults and those with underlying comorbidity, the GSK RSV vaccine candidate has the potential to deliver clinically meaningful impact for older adults and for public health. We look forward to continuing to work with the RSV Adult Working Group over the coming months. Pending FDA approval, we look to enable access to the vaccine ahead of the 23-24 RSV season. With that, I'll thank you once again for your valuable time today, and we'll stop here for any potential questions.
Thank you very much for that presentation. I see 3 hands raised. We'll go to Dr. Talbot first.
I have to say I'm extremely excited for this vaccine for someone who's done RSV research in older adults for a while. And I'm also excited to see the prevention of acute respiratory illness, because that will likely also have large impacts on hospitalization. So way to go. I had a couple comments and a question. First comment was that really those over 70 and over 80 should have been a much higher number of those enrolled, so that you could actually look at vaccine efficacy in those groups, because those are actually the groups that have the highest morbidity and mortality over the 60 to 69-year-olds. The real question that I have is there have been a couple cases of GBS reported. Can you talk about that? And were they in the placebo group or the vaccine group? Thanks.
Thank you so much for your question. There was one case of GBS, a single case throughout the program that was observed in the open label immunogenicity study. I'll invite my colleague Peggy Webster, Head of Safety for Vaccines, to make a comment.
Thank you. I just want to do a quick sound check and make sure that you can hear me.
Very clear.
Thank you, Bish. So, as Bishoy alluded, the single case of Guillain-Barré syndrome was reported from our open label RSV 004 study. And this was the only case that was observed in the aggregated safety analysis across all studies in the RSV Older Adult Project, with data from more than 15,000 exposed participants. For this particular case, the investigator considered that there was a reasonable possibility that the event was associated with the RSV Older Adult vaccine. With the information we received, the case met the 3rd level of diagnostic certainty according to the Brighton Collaboration case definition of GBS. It did occur within the risk window for GBS as a vaccine-related reaction. However, the clinical signs and serological parameters reported to us can be present in several neurological disorders, and neither a neurological consultation or electrophysiologic testing were reported. Additionally, it was not reported if alternative causes for the participants' symptoms were investigated. As such, the company concluded that the reported information was not sufficient to either confirm the diagnosis of Guillain-Barré syndrome or exclude possible alternative etiologies. And again, as Bishoy noted during his presentation, the participant fully recovered.
Thank you. Next, we'll go to Dr. Paling.
Oh, to me?
Yes, Dr. Paling, yeah.
Oh, I'm sorry. I heard Dr. Cannon. My apologies. All right. So thank you, Dr. Rizkala, for a fantastic presentation.
This is really important, and I'm thrilled that you're doing a 3-year studies. I can report from the children's hospitals across the United States are seeing a very significant early RSV season, and there will be lots of very important data. I also want to applaud the approach of comparing placebo, a 1 dose, and an annual dose. I think this is going to be really important. My question to you is about the adjuvant. Could you please, my question to you is about the placebo. What is the placebo in this study?
It's saline.
It's a saline, okay. And then my second question is, if I understood correctly, the adjuvant is also used in the shingles vaccine. And have you compared persons that have received the shingles vaccine with those who haven't in the trial? And is there any information about getting both? Thank you.
Thank you for the question. So, yes, the adjuvant in our RSV vaccine is using the ASO-1E adjuvant system. This is distinct from the ASO-1B that is used in our shingles vaccine, which contains double the amount of adjuvant in that vaccine. We haven't looked specifically at those that have received shingles vaccine in our study, so I can't really make a comment about that today.
Thank you.
Dr. Cotton? Yes. Apologies, I'm going out of order. Ms. Bata next.
I just wanted to hear a little bit more expansion about the criteria of frailty. The notes here are just too small, and I just would wonder if you could please talk a little bit more about that criteria.
Yeah, thank you for your question. We do have one backup slide in the deck that might help the voiceover here. So slide 25, if you can go to slide 25. Yeah. The frailty was assessed using the gait speed test, but I'll hand over to my colleague Veronica Hulstrom, who's the head of clinical for the program, to take you through a bit more of the details.
Thank you, Bishop. So basically, as you can see on the slide, we assessed frailty by a gait speed test. Basically, the test allows 2 lengths of a walk where you have 3 meters or 4 meters, and the participant walks down the hallway through a 1-meter zone for acceleration, a central 4-meter testing zone, and 1-meter zone for deceleration, as you can see illustrated on the slide. Then you can see that the timing is recorded and reported to us in the ECRF and further grouped as follows. So we looked into the fit participants. That is a participant with a walking speed above 1 meter per second or equal. Then we have the pre-pro participants with a walking speed between 0.4 and 0.099 meter per second. And you have the frail participants assessed as participants with a walking speed below 0.5 meter that is not able to be performed the test. And the reason, as you can see, we have also included a few examples, is could be tired but unable, could not walk, unassisted, not attended, and study staff or participant felt unsafe. Or a participant that was unable to understand the instructions. And as you can see that the gait speed test is a component of the short physical performance battery measurements.
Does that help answer your question?
Yes, thank you so much.
Thank you.
Thank you. Now, Dr. Cotton. Thank you very much for presenting this interesting information. This could really be a significant vaccine for the immunocompromised host community in that they really can suffer from severe, life-threatening, and deadly RSV infections. I know that population was omitted from this initial from the initial trials, but hopefully eventually they will be included and hopefully will benefit from this vaccine. I remain concerned about the case of GBS, especially Guillain-Barré syndrome. Even though it's a different adjuvant, Guillain-Barré syndrome was also seen with Shingrix, and actually the package insert for Shingrix has been amended to include information about Guillain-Barré syndrome. And
I'm wondering if the company is doing further work to look at this, or it's unfortunate that they did not have a neurologic evaluation of that patient with presumed GBS. That's makes things challenging for everybody. But I do remain significantly concerned about this in that the elderly population for whom this vaccine is geared is at higher risk for developing Guillain-Barré syndrome. And when we talk to patients about safety, it's something that is somewhat concerning with Shingrix, and I guess it remains to be seen what the overall outcome will be with this. But I am concerned, and I'm wondering if the company has thoughts about whether it could be related to adjuvant, in that both of those vaccines are adjuvanted.
Thank you for your question, Dr. Cotton. I will invite my colleague, Peggy Webster, to comment.
Yes, thank you, Dr. Cotton, for your question and for your comments there. So yes, last year the findings from a post-marketing observational study among the U.S. Medicare beneficiary population, which was performed to evaluate for an association between vaccination with Shingrix and GBS, Guillain-Barré syndrome. Those were published, and the primary analysis, which was claims-based and included all doses, found a slightly increased risk of Guillain-Barré syndrome during the 42 days following vaccination with Shingrix, with an estimated 3 excess cases of Guillain-Barré syndrome per million doses administered. The benefit-risk balance remained in favor of vaccination, as Shingrix is efficacious in decreasing the risk of herpes zoster and its complications. The analysis that was performed by the CDC, CMS, and FDA was robust and provided new and significant safety information for Shingrix about a potential risk that is serious or otherwise clinically significant, and therefore has implications for prescribing decisions or for patient management. The company continues to closely monitor reports of GBS associated with Shingrix vaccination through proactive enhanced pharmacovigilance, and incident cases of GBS are being measured as one of the objectives of an ongoing targeted safety study. We would be happy to follow up with the working group after the meeting to provide a response with additional information regarding the safety profile of Shingrix if that's desired.
Thanks. I think that would be very helpful for us to have that information. Furthermore, so it's good to hear, I guess, that there will be more, purely with respect to the trial, that there'll be hopefully more RSV disease activity this year so we can better analyze the vaccine. I guess I remain concerned that there were overall very small numbers of patients who developed RSV infection, and then what the impact would be on the data. I don't think that the company can really answer that question, other than we all remain concerned that the overall numbers of infected patients was quite low.
Well, thank you for the comment, Dr. Cotton. I'll invite the head of our R&D organisation, Dr. Phil Domerter, to make a comment.
I think it's important to distinguish between the number of overall cases of RSV illness and severe RSV illness. We actually had quite a good number of cases of RSV illness. There were relatively few hospitalizations, however, and cases of severe illness. We will be following through the successive 2 seasons, so expect to accumulate much more data over the course of those 2 seasons.
Thank you. I'll go next to Dr. Chen.
Yeah, congratulations for the positive efficacy signal. I think it's really exciting for the RSV vaccine field to see, a successful candidate. I think I'll just reiterate some of the comments that you've heard from some of the other members. Is that it would be nice to see this kind of efficacy in frailer older adults, to also kind of make sure that we can understand the efficacy of this vaccine in older adults that have limited independence, as opposed to what this population looks like, are mostly persons who are able to, again, be fit or fall into the pre-frail category. Certainly, nursing home, homebound population of older adults continue to be a concerning part of the population that suffer from the burden of RSV disease. So just continuing to look at older adults with also multiple chronic medical conditions, the immunocompromised, again, will be very helpful for us to understand the efficacy of this vaccine. Thanks.
Thank you so much for your comment. The frail population, as assessed by the Gates speed test, represents approximately 1.2% of the recruited population. So we haven't been able to accrue enough cases to be conclusive on the efficacy there. However, when you look at the efficacy in the pre-frail population, which was observed to be 92.9% in our study, you look at the efficacy in those with at least one pre-existing comorbidity of interest, 94.6%, gives us good confidence that this vaccine will infer a protective benefit in these at-risk subpopulations in the older adult population.
Thank you. And we have 5 more hands raised. I'm going to ask our members to keep the questions brief and the responses brief as well. I'm going to move to Ms. McNally.
Thank you. I'm the consumer representative, and I just wanted to see if you could answer this question for me. Dr. Cotton mentioned that there may be providers who have some reluctance about co-administration of this vaccine with other vaccines, and I wondered if GSK has a response to that.
So we today have demonstrated the immune response when co-administration of our RSV vaccine with inactivated quadrivalent influenza vaccine. There is an extensive program in place that evaluates the co-administration of other vaccines that are used in older adults, starting with a priority dose of flu, so looking at high-dose flu and looking at adjuvanted flu. These studies have been posted on clinicaltrials.gov and have initiated recruitment, and we'll come back to the working group with further details of those studies. Now, moving beyond influenza, there will be other co-administration studies in this older adult population that will be initiated, including COVID with mRNA vaccination, which potentially in an endemic context could be potentially used with overlapping seasonality.
Thank you.
Thank you. Dr. Sanchez?
Thank you, and thank you for the presentation. It certainly is exciting news, and hopefully it can spur adults to more respiratory viral testing as many enter my NICUs. But my question is, among those who developed RSV who had received the vaccine, did you see any more severe illness? What was the characteristic of the illness in those patients? And secondly, are you studying at all any prevention of transmission? Are you doing any asymptomatic testing? Will it prevent transmission within the household to others? I presume these adults probably obtained it from children, but I think to look at other modes of transmission would be important. Thank you.
No, thank you so much for your question, Dr. Sanchez. So the trigger for this study is symptomatic disease, both upper and lower respiratory tract disease. That's our ARI definition, and that's the trigger. So we haven't looked at asymptomatic cases. This is acute respiratory illness as the trigger. But to answer your question about medical utility or medical attendance, we do have a study, a slide in the backup, slide 32, if we can call that up. But it's a very good question. So slide 32. Excellent. The previous one. This is excellent. So this is looking at medical attendance beyond the protocol-defined visits in the study. And on the left, you can see the RSV pre-F3 arm, and on the right, you can see the placebo. This is looking at those participants that experienced a ARI or a lower respiratory tract disease, looking at the number of those participants that requested or required additional medical attendance. So if you look at the ARI arm, for example, in the active arm, 29% of participants experiencing an ARI sought additional medical attendance. Those in the placebo, 40% sought additional medical attendance for an ARI-related visit diagnosis. For those with lower respiratory tract disease in the vaccine arm, 42.8% sought additional medical attendance compared to 60% in the placebo arm. We also have patient-reported outcomes, which has demonstrated a symptomatic benefit in these cases in the active arm.
Actually, Dr. Sanchez, I'm going to move on. We have 2 quick questions, and we have another presentation, and I still need to get us done on time today. So, Dr. Lair, Dr. Long, and then we're going to move on to the next session.
2 clarifications. You said this is engineered antigen. Is that recombinant engineering?
Yeah, I'll invite my colleague Phil Dormans, head of R&D, to make a comment.
That is correct. There are mutations in the protein sequence to stabilize it into prefusion conformation. These are the mutations developed at the NIH as part of their DS1, which was the prototype for this vaccine.
And on slide 12, you have a list of, on the right-hand side, the cases of placebo. Are those all 3 cases, 3 lines separate? So when you have 95 ARIs and 40 LRTDs and 17 severe, are those 3 separate categories, or the severe subset of the LRTD subset of the ARI?
Thank you for your question. I'll invite my colleague Veronica Hillstrom, head of clinical, to make a comment.
Thank you. Just to kind of make sure that I understood the question correctly. The question was whether or not the RSV-RE vaccine efficacy was containing the subset of the remaining.
Is there overlap in the cases? So yes.
No.
Yes.
No, actually, my question is more, if I count the placebo groups, I could either have 3 different groups adding up to about 150, or I could have 1 group of 95 and then 2 subsets.
So it is a subset, yes.
Thank you.
So it is a subset. Thank you. So it's the 95 cases that experienced, according to the definition of ARI, of which 40 went on to be classified as lower respiratory tract disease, of which 17 were considered severe.
Thank you.
Thank you, Dr. Long. Last quick question.
Yes, do you have information on all-cause acute respiratory illness or lower respiratory tract disease to answer the safety question that this is not detrimental for other infections, or possibly is it helpful and the burden is underappreciated? And did you have anybody in this group that had coronavirus infection, and how did they do?
Thank you for the question. For the coronavirus, I believe we do have a slide in backup. Let me just.
I don't know the number for that. So maybe while you're finding the slide is, we also looked into vaccine against any ARI on the efficacy where we did not observe any effect of the vaccine. So it was.
Yeah, I don't have the slide in backup in terms of the COVID, but from memory it was about 0.5%.
For COVID, we did not analyze the COVID occurrence group as such. So we have not done that subgroup analysis.
But thank you for your question.
I just want to clarify quickly. Dr. Lang, your question was, were there any cases of RSV in the LRTI? Is that essentially it? Yeah. Do you know what proportion? Where are these all? These are all RSV related. Not
yes,
all
they
cause.
So,
okay.
They make the definition for ARI. They go on to be confirmed as RSV associated by RT-PCR.
Okay. Thank you.
And beyond, at other respiratory viruses, that was not part of the design of the study.
Okay. Thank you very much. All right, we'll move on to the next session. And thank you very much for your presentation. And really great to see this data. We'll move on to a presentation by Pfizer. Dr. Gertman will be speaking about the safety and efficacy of bivalent RSV vaccines in adults 60 and older.
Good morning. I'm just checking that my voice comes across.
Yes, we can hear you. Thank you.
Thank you very much.
I'm sorry, could you please give me the sharing privileges, please? Oh, I see it now. Thank you. Can the slides be seen, please? Can you confirm?
No.
Are they showing?
Nothing showing.
This is Michael Malgar, the CDC lead for the work group. Give us 1 second to give control. Dr. Snow, you should be able to share your screen now.
Thank you.
Good morning. Thank you to the ACIP for the opportunity to present today. My name is Alejandra Kurtman, and I am in the Vaccine Clinical Research and Development Group at Pfizer. I am pleased to present to you the safety and efficacy data for the Pfizer bivalent RSV prefusion F vaccine in adults 60 years of age and older. The Pfizer RSV pre-F consists of bivalent stabilized prefusion F proteins based on prefusion F conformations from the RSV-A and RSV-B strains. RSV pre-F elicited high neutralizing titers for both RSV-A and RSV-B in phase 1-2 studies that initially supported both of our targeted indications, which include maternal immunization for the prevention of RSV lower respiratory tract illness in infants and active immunization of older adults for the prevention of RSV-associated lower respiratory tract illness. Our older adult clinical development program has been comprehensive and includes adults 18 years of age and older in 6 different studies. We tested 3 dose levels with and without aluminum, and also formulations with and without CpG. Early on, we demonstrated that RSV pre-F was immunogenic in a non-adjuvanted formulation, and adding aluminum or CpG conferred no immunological benefit. The final dose selected is 120 micrograms containing 60 micrograms of A and 60 micrograms of B strains, and the vaccine is unadjuvanted. For this presentation today, I will focus on the results of our phase 3 pivotal efficacy study. RENOIR, which is the vaccine efficacy study in older adults, is a global phase 3 study designed to evaluate efficacy, immunogenicity, and safety of the bivalent prefusion F subunit vaccine. The RENOIR study is being conducted at 240 sites in 7 countries, including the US. The study is targeted to enroll up to 40,000 participants 60 years of age and older. Participants are randomized 1-to-1 to receive either RSV pre-F or placebo, and randomization is stratified by age. Participants are eligible if they are healthy or have stable chronic conditions, including stable cardiopulmonary disease, diabetes, asthma, or COPD. Immunocompromised persons or those who have serious chronic disorders are excluded. Regarding safety monitoring, a subset of participants completed a daily e-diary to monitor local reactions and systemic events for 7 days after vaccination. Unsolicited adverse events are captured through 1 month after vaccination in all participants, and serious adverse events and newly diagnosed chronic medical conditions are captured through the end of the study. In addition, all participants undergo active surveillance for acute respiratory illness by completing a weekly e-diary. If acute respiratory illness symptoms arise, participants perform a self-nasal swab and they contact the investigational site. The site conducts a clinical assessment capturing details of any ARI symptoms. Depending on the investigator's judgment, the illness visit may be conducted in person or remotely. When an in-person visit is completed, an additional nasal swab is collected. Finally, a subset of participants had blood draws at 3 pre-specified time points to assess immunogenicity. I will not be presenting that data today. Now, I would like to describe the key study definitions, starting with acute respiratory illness, which is defined as having one or more of the following symptoms lasting more than 1 day: nasal discharge, nasal congestion, sore throat, cough, sputum production, wheezing, or shortness of breath. These are the symptoms for which all participants complete the weekly e-diary surveillance entry, which triggers a self-nasal swab and the contact with the investigational site that I described to you on the prior slide. Lower respiratory tract illness is an acute respiratory illness with 2 or 3 signs or symptoms of new or worsening cough, sputum production, wheezing, shortness of breath, or tachypnea. And severe LRTI is defined as LRTI plus at least one of the following objective criteria: hospitalization due to RSV, new or increased oxygen supplementation, and new or increased mechanical ventilation, including CPAP. I will not be presenting today an analysis on severe illness, as we didn't accumulate enough severe cases at the time of this analysis. A case definition of RSV-associated ARI or RSV-associated LRTI is made when a participant has at least 2 or 3 symptoms or severe illness and a positive validated RSV PCR test. Now that I described to you the study definitions, I would like to go over the study objectives of the study. For safety, the objective was to describe the safety profile of the RSV pre-F vaccine. The primary efficacy objective was to demonstrate the efficacy of RSV pre-F in preventing RSV-associated lower respiratory tract illness with at least 2 or at least 3 signs or symptoms in the first RSV season following vaccination. There are several secondary efficacy objectives, including efficacy against RSV-associated acute respiratory illness and severe RSV-associated LRTI in the first season. Additional objectives include efficacy of the vaccine in the second season and across 2 seasons. The focus of today's presentation is safety, LRTI, and ARI. As with many vaccine efficacy studies, Renoir was designed as a fixed event trial. The analysis I'm presenting today was a per protocol pre-planned interim analysis. For the endpoints I'm presenting today, these are considered the final analysis. We have agreement with regulatory agencies on licensure criteria, including vaccine efficacy with a lower bound of at least 20%, as well as agreement on the case definitions for lower respiratory illness. We have adjusted the type 1 error for this interim analysis. I will now present the interim analysis results of the study, starting with enrollment and demography. We enrolled 34,284 participants, and they're all included in the safety database. In terms of demographic characteristics, the RSV pre-F and placebo groups were balanced when looking at sex, race, ethnicity, and age. About a third of the participants were 70 to 79, and about 6% in each group were 80 years of age or older. In terms of pre-specified significant conditions, approximately 50% of the participants had one medical condition. 15% in each group had at least one chronic cardiopulmonary condition, and about 19% in each group had diabetes. I will now share local reactions by maximum severity within 7 days of vaccination, which were more frequently reported in the vaccine group than in the placebo group, with a 12.1% versus 6.6% respectively. The most frequently reported local reaction was pain at injection site, followed by redness and swelling. Most local reactions were mild, lasted 1 to 2 days, and resolved. Systemic events are shown on this slide by maximum severity within 7 days after vaccination. As you can see, the proportion of participants who reported a systemic event within 7 days were similar in the vaccine and the placebo group, with 27.4% and 25.7% respectively. The most frequently reported systemic events were fatigue, headaches, and muscle pain, and were similar across the groups. There was only one grade 4 event of a fever of 40 centigrades on the day of vaccination in a participant who is in the placebo group. Most events were mild or moderate and of short duration. And for unsolicited adverse events from vaccination through the 1-month follow-up, about 9% of participants in each group reported any adverse event. The frequency of related, immediate, severe, and life-threatening adverse events were similar in the vaccine and in the placebo group. At the bottom part of the table, you can see that newly diagnosed chronic medical conditions were also similar in both groups. There were 3 serious adverse events deemed by the investigators to be related to the vaccine, and I will present them to you in the next slide. Adverse events leading to withdrawal from the study or leading to death were similar in the vaccine and in the placebo group. Adverse events leading to death were reported in 52 RSV pre-F recipients and 49 placebo recipients. The primary causes of death most frequently reported were in the system organ class of cardiac disorders, and none of the deaths were assessed as related to the study. As I just mentioned, 3 RSV pre-F recipients reported SAEs assessed as related by the investigator. In the interest of time, I will review them briefly. The first was an allergic reaction in a 61-year-old female 7 hours after vaccination, which resolved on the same day. It was seen to be a delayed allergic reaction and not anaphylaxis. The second event is a retrospective diagnosis of a Miller-Fisher syndrome in a 66-year-old female in Japan with a limited workup. An anti-GQ1B IgG was negative and no conduction studies were done. This case meets level 4 of the Brighton collaboration. And the third event is a Guillain-Barré syndrome in a 66-year-old male in the United States who developed a non-ST myocardial infarction requiring angioplasty 7 days after vaccination, followed by slow progression of lower extremity weakness and ataxia. The conduction study was consistent with acute demyelinating polyneuritis of the lower extremities, and this case meets Brighton collaboration level 1. All of these cases were evaluated by our external DMC, who didn't identify any safety signal and recommended to continue enrollment into the study. As of today, we have more than 20,000 participants who have been exposed to the vaccine, and we have not seen any additional unexpected serious adverse event. Now I would like to turn your attention to the efficacy of the vaccine. At this pre-planned analysis, when looking at RSV-associated LRTI defined by at least 2 symptoms, there were 11 cases in the vaccine group and 33 in the placebo, with an observed efficacy of 66.7 and a lower confidence interval of 28.8%. For those who had at least 3 symptoms, there were 2 cases in the vaccine group and 14 cases in the placebo group, resulting in vaccine efficacy of 85.7 with a lower confidence interval of 32%, indicating an even higher efficacy against more severe disease. In terms of the difference between the 2 groups, the figure here shows the frequency of LRTI signs and symptoms for the RSV LRTI cases with 2 or more symptoms on the top part of the figure, and this is also displayed at the bottom with 3 or more symptoms or only 2 symptoms. Among the RSV LRTI cases with 2 or more symptoms, cough and sputum production were the most common symptoms reported. But in the dark blue bars, for the cases involving 3 or more LRTI symptoms, wheezing, shortness of breath, and tachypnea were more frequently reported, which is consistent with more severe disease. This slide shows the cumulative case accrual curve from day of vaccination for RSV-associated LRTI with at least 2 symptoms. The blue line is in the vaccine group, and the gray line represents the placebo group. Vaccine efficacy is shown after day 15, and persist for at least 6 months, sufficient to cover a typical RSV season. And similarly, this is the cumulative figure for RSV LRTI with at least 3 symptoms. And again, vaccine efficacy also persists for at least 6 months. Vaccine efficacy in those with 2 symptoms at the top or 3 symptoms at the bottom of the slide was consistent across different subgroups, including age and those with pre-specified high-risk conditions. Please note that for each subgroup, the numbers are small and the confidence intervals are a little bit wider. Finally, when looking at RSV-associated acute respiratory illness, RSV-PreF was also efficacious with a case split of 22 cases in the vaccine group and 58 cases in the placebo group, for a vaccine efficacy of 62%, with a lower confidence interval of 37%, which indicates that RSV-PreF also protects against less severe disease, primarily upper respiratory disease. On the right side, you see the cumulative curve for acute respiratory illness, where the light blue is the vaccine group and the gray is in the placebo. When looking at efficacy by subgroup A and B across those with 3 symptoms, 2 symptoms, or just A or I, vaccine efficacy was consistent for both strains as well. In conclusion, the interim analysis for the Renoir phase 3 pivotal trial has demonstrated that RSV-PreF was safe and well tolerated. Local and systemic events were mostly mild to moderate and short-lived, and the adverse event profile did not suggest any safety concerns for RSV-PreF vaccination in adults 60 years of age and older. RSV-PreF was highly efficacious in reducing RSV-associated lower respiratory tract illness in adults 60 years and older, and also in reducing RSV-associated ARI in this age group. The study is ongoing, and we anticipate having additional data in the future. I want to conclude my presentation by acknowledging and thanking all of those who make this possible: the clinical trial participants, their families, the sites, our investigators, the CRO, our partners, and their staff. I'm happy to take any questions now. Thank you.
Thank you very much for that presentation. I'm just going to ask my colleagues if you still have a question or if it's residual from last time, if you could put down your signs, and then I'm going to ask the favor that you turn your signs towards me just so I can see them. I have trouble on the angle. Dr. Talbot.
Thank you for the great presentation, and thank you for the very exciting data. Once again, we can prevent ARI, we can prevent hospitalizations. I was hoping you could go back to the slide that showed the numbers of participants by age.
Yes.
So it's great that we're testing a vaccine designed for older adults and older adults, but it is really underpowered for those 70 and above. And I think it's really important when we do these studies, we do them in the adults that we intend to use them in with the most morbidity and mortality. Second thing is I didn't see any data on frailty, which is incredibly important for us to distinguish. VE is higher in those who are not frail and lower than those who are frail, and so that gives us a concept of how well they'll be used and how effective they'll be. My second question is about the GBS Miller-Fisher. You showed those cases. Were those in the placebo or the active component?
Thank you, Dr. Talbot. So to answer your first question, we have about 30% of the participants in the 7 to 79, and I agree that the number on those who are 80 and older is not as good as maybe we would all want to have. As you probably know, it's harder to enroll those subjects in clinical trials. But we studied, we met the numbers that we targeted per protocol, and we will have, hopefully additional data. We will continue to do other studies where I fully agree that it would be good to have more participants who are older than 80. With respect to the GBS and Miller-Fisher syndrome, both cases were in the vaccine. They were active recipients of the RSV-PreF vaccine. The Miller-Fisher syndrome, which, as I mentioned, was a Brighton for collaboration, it didn't have enough information to really document, and it has also an alternative diagnosis, potential alternative cause, as the subject developed a sore throat, and what it seemed to be like a viral syndrome, approximately 7 to 8 days after vaccination. The second case, which is the GBS, the case is confounded by a participant who had a myocardial infarction, which required a procedure. Immediately after that, he developed, as I mentioned, back pain that progressed to lower extremity weakness. So it's a complicated case as well, and so both cases have potential additional causes other than the vaccine. In the opinion of the company and our evaluation, it's hard to confirm that these cases could have been related to the vaccine.
Yes, but both were in the vaccine group and not the placebo. Correct?
They were not in the placebo.
Okay, and then last question, do you have any data on re-immunization?
So I want to come back to the frailty that you mentioned. Is something that has not been assessed, particularly in this study. We have data on revaccination from our phase 1-2 study on subjects who receive a different dose, was 240 micrograms, and they have been revaccinated a year later. And actually, we see that the GMTs, actually the neutralizing antibody titers, go up again, and I believe that I have a backup if you want to see. But I, in the interest of time, I'm not sure if we want to show that. We anticipate potential revaccination in the study depending on what happened during the second season and the cases that we accumulate.
Thank you. We'll move on to Dr. Paling. And I'll just remind folks, if you can do brief questions and brief responses, we'd really appreciate it.
Okay, 2 quick questions. Thank you, Dr. Bertman. Can you please clarify what is the placebo?
The placebo is a matched lyophilized that looks identical to the vaccine, which obviously doesn't have the active ingredients.
Okay, could you say that a little louder? It was hard to hear in this room. I apologize.
Oh, the placebo is a lyophilized match that doesn't have the active ingredients. It doesn't have RSV pre-F. But it looks exactly the same. It's the same cake, and it's diluted in the same way than the active vaccine.
Okay, so what I wanted to also understand is in the vaccine, we understand that's a bivalent stabilized prefusion F, but what else is in there? Is there adjuvants or anything else in there? And I'm assuming that the placebo is just whatever is making up the vaccine without the active component. Thank you.
Yeah, so you are correct. The vaccine has no adjuvants. It's just the active ingredients. And as you said, the placebo is exactly the same without the active ingredients.
Thank you, Dr. Sanchez.
Yes, thank you for the presentation. I had a question about the primary outcome on slide 7, and was a bit confused about the differentiation between the acute and the lower respiratory tract symptoms. If you could explain that. And then my other question is, any enhancement of RSV disease after immunization with the active vaccine? Thanks.
Yeah, so if you can go back to the first slide, please. Yeah, so the ARI symptoms are the ones that the subject may experience, and they have to last for at least 1 day, and are the ones that you see on the first row. So that is what triggers a swab and a consultation with the investigational site. Once that happens, so once the site is aware that the subject has at least one of those lasting more than a day, the information about the LRTI, which is the combination of 2 or 3 symptoms of what you see on the second row, is collected by the site, and that's what is entered into to our information to make the case, of course, it has to have a positive PCR as well.
So acute would only be one of those symptoms, not one or more.
For a day, yes.
And then the lower is two or more of those.
Correct.
Okay, thank you.
Dr. Cotton. Thank you very much for your presentation. I had just a small follow-up question about the GBS cases. And in general, we call Guillain-Barré syndrome, we use the term Guillain-Barré syndrome. My understanding is that Miller-Fisher is related to Guillain-Barré syndrome. And can I ask for further specification as to why it was called Miller-Fisher syndrome? Was there something different about that case? Or could it be classified as Guillain-Barré syndrome? And yeah, if you could elaborate on that, and also on the timing of when that occurred. Was it within the first few weeks after vaccine exposure? Thank you.
Yeah, thank you. I would like to invite my colleague Maria Magdalena Lino, who is the global safety lead for the RSV program, to comment and answer your question.
So as you mentioned, I mean, this was diagnosed as Miller-Fisher because it has mainly ocular features, and respectively has a cranial nerve disorder, mainly the third cranial nerve. And I would like to underline this is a diabetic patient, and this is quite often seen in diabetic patients. Now, regarding the
I'm sorry, it's really hard. Sorry, it's hard to hear in this room. There's an echo. Can you repeat what you said? Sorry for that.
To be, an ascending paralysis or we have to say that the subject, aside of being diabetic, she 8 days after vaccination reported to be with fatigue, sore throat, dizziness, and 3 weeks later then presented with diplopia and prestige palm salts. Another important point to make is that the subject didn't need any therapy and then recuperate completely within a couple of weeks and did not perform any single diagnosis test to confirm the GBS. And the diagnosis was a retrospective diagnosis, and important to confirm that the only test was done to confirm for the GBS, the GIQ antibodies was negative.
Thank you. I'm gonna. We have one more hand raised, but just to both Pfizer and GSK, we'll defer to their work group, who I know is going to be asking questions about safety, just to make sure we can capture more details so that we can see that consistently. Thank you very much. And last question to almost last question to Ms. McNally.
Thank you. I'm wondering if you could also provide a response to the potential concern that providers may have regarding the co-administration of this with other vaccines. Thank you.
Ms. McNally, I'm not sure if I got the last part of your question. Are you asking about co-administration with the COVID vaccine?
Yeah, not necessarily just COVID, but yes, vaccines in general.
Yeah, so we have an ongoing study currently, which already is completed, and we will co-administration of flu vaccine, and we expect to have results for those, within the next few months. And we have additional plans to evaluate this vaccine with other vaccines that are given to older adults.
Thank you so much.
Thank you. And last question is, do you have any data on asymptomatic infection or transmissibility? Because I think for all of our respiratory vaccines, it's going to be really important for us to make sure we have information on that. It's been critical for COVID, and I feel like we haven't seen that data, so we're asking for it up front from both companies.
Thank you, Dr. Lee, for the question. At the present time, we don't have data on either one.
Do you have plans to incorporate that in future work?
We will take this under consideration and see if we can execute those studies.
Thank you very much. Okay, with that, we are going to move on to Dr. Michael Melgar, who is going to present on the adult RSV workgroup considerations.
My name is Michael Melgar, and I serve as the CDC lead for the work group for RSV vaccines in adults. Today, I'll present a brief summary of the data reviewed by the work group and the current work group considerations. First, here are the current policy questions being considered by the work group. Should vaccination with GSK's investigational RSV vaccine be recommended for all older adults? And should vaccination with Pfizer's investigational RSV vaccine be recommended for all older adults? The definition of older adults should be aligned across the policy questions unless there's a strong reason for a different threshold. Potential age thresholds being considered by the work group include, but are not limited to, 60 years and older and 65 years and older. As we've seen from both manufacturers, vaccine efficacy was largely invariant to participant age in the trials, provided there were enough events to evaluate it in each stratum. Therefore, the age threshold for a policy recommendation must be informed by other considerations. To revisit evidence pertaining to RSV-associated risks by age, here are seasonal rates of RSV-associated hospitalizations among U.S. adults, stratified by age, estimated from CDC's RSV Hospitalization Surveillance Network, or RSVNet, during the 4 most recent RSV seasons before the COVID-19 pandemic. RSVNet provides active, population-based surveillance of laboratory-confirmed RSV-associated hospitalizations at sites in 12 U.S. states. The combined catchment areas are estimated to account for almost 9% of the U.S. population. You can see that hospitalization rates were substantially higher among adults 70 to 79 and 80 years or older compared with younger age groups. Adults 60 to 64 and 65 to 69 experienced intermediate rates of hospitalization. Additional evaluation, including number of hospitalizations potentially averted by vaccination, will be shared with the work group and with ACIP before a policy recommendation is brought forward. Evidence reviewed by the work group to date includes the epidemiology and burden of RSV in U.S. adults, including seasonality, population-based rates of medical visits, hospitalizations, for example, those I just showed, and deaths, as well as basic RSV virology and immunology, and the safety and efficacy data presented by GSK and by Pfizer. Now I'll discuss the work group's summary and interpretation of the data shared by the manufacturers. Both clinical trials showed significant efficacy against RSV, lower respiratory tract disease or illness, which was the primary endpoint in both trials. The efficacy point estimates exceeded 60%. Notably, efficacy cannot be compared between trials due to differences in outcome definitions. However, in each trial, efficacy estimates were based on fewer than 50 total events of the primary outcome. The table here shows the number of events of the primary outcome by trial and by vaccine or placebo arm. So, why were there so few cases of symptomatic RSV infection? For one, clinical trials often enroll a healthier population compared with the general U.S. population. And also, we know that both trials were conducted during periods of atypical RSV seasonality in the United States, likely attributable to the COVID-19 pandemic. To characterize that a bit better, I'm showing here monthly number of RSV-associated hospitalizations among adults 65 years and older that were reported to RSVNet during the 3 most recent pre-COVID-19 pandemic RSV seasons and during the COVID-19 pandemic. Importantly, RSVNet has historically only conducted surveillance during October to April of each season, which is why the data are disjoint in this figure. Continuous surveillance was temporarily established during the COVID-19 pandemic in response to atypical RSV seasonality. Pre-pandemic, RSV hospitalizations in this population reliably peaked every January. However, there were almost no RSV hospitalizations in January of 2021, and there was an unusual summer rise in hospitalizations, which eventually peaked in December 2021 before dropping quickly. The GSK and Pfizer trial periods are labeled here as well, showing that they coincided with the unusual RSV seasonality. The work group notes that the RSV vaccine trials were underpowered to estimate efficacy against more severe clinical outcomes such as hospitalization and death. There were fewer than 5 RSV-associated hospitalizations in each trial, and neither trial recorded any RSV-associated deaths. However, we know that the burden of RSV-associated hospitalizations is high among older adults in the United States. Here are RSVNet estimates for total RSV-associated hospitalizations among adults 60 years and older in the U.S. occurring during the 4 most recent pre-COVID-19 pandemic RSV seasons. I would note that estimates have wide 95% confidence intervals, but the lower bounds exceed 40,000 hospitalizations during every season. Notably, estimates from the 2 most recent pre-pandemic seasons were presented by Dr. Fiona Havers at the 12th International RSV Symposium in Belfast last month. And RSVNet estimates are conservative compared to published literature. A recent Pfizer-sponsored meta-analysis estimated that at least 106,000 annual RSV hospitalizations in the United States among U.S. adults 65 years and older. Although neither trial can provide efficacy against RSV-associated hospitalization, we might expect efficacy against more severe clinical outcomes to be at least as high as efficacy against the primary outcome. This is based on the trend evident in both trials of increasing efficacy with increasing severity of the clinical outcome, with point estimates of efficacy against lower respiratory tract involvement exceeding those against any acute respiratory illness, and efficacy against more severe lower respiratory tract involvement exceeding that against less severe. Again, due to different outcome definitions, efficacy cannot be compared across trials. The efficacy of either vaccine beyond the first RSV season is unknown. Both trials are ongoing, with multiple years of follow-up planned. However, data from only the first year will be available for consideration of these first policy recommendations. There's no established immunologic correlate of protection for RSV, limiting the utility of immunogenicity data in informing duration of protection. The need for revaccination and the appropriate time interval are yet to be determined. The work group also noted that cases of Guillain-Barré syndrome were reported after vaccination with both investigational vaccines. GSK reported no cases in their pivotal phase 3 trial that enrolled almost 25,000 participants. However, they did report 1 case in a different phase 3 study evaluating the safety and long-term immunogenicity of different revaccination intervals with their vaccine. To date, of over 1,650 participants in that trial, all received exactly 1 dose of the vaccine. In other words, none have yet been revaccinated. The case of Guillain-Barré syndrome occurred 9 days after participant vaccination. In total, GSK reported 1 case of Guillain-Barré syndrome among over 15,000 older adults who received their investigational vaccine across all studies. Meanwhile, Pfizer reported 2 cases of Guillain-Barré syndrome, including 1 which was classified as a case of the Miller-Fisher variant. In their main phase 3 trial, which was somewhat larger than GSK's, the cases had onset 8 and 11 days after vaccination, respectively. Pfizer did not report any additional cases of Guillain-Barré syndrome in their other trials of this vaccine. So in total, there were 2 cases among approximately 26,000 persons who received their investigational vaccine. All cases had onset during the 42-day risk window post-vaccination used in CDC surveillance. However, the significance of 1 to 2 cases observed in safety databases of 15 to 26,000 persons is unclear, and the population-based background rates of Guillain-Barré syndrome are known to increase with increasing age. Notably, RSV infection has also been associated with Guillain-Barré syndrome in case reports and case series, but a causal link has not been established. The work group continues to review and interpret the safety evidence. Finally, uptake of a novel RSV vaccine among older adults will depend on patient and clinician education. The adult immunization schedule, as Dr. Cotton noted, is becoming more complex, including multiple vaccines with revaccination intervals. While RSV is well known as an important pediatric pathogen, it's likely less well known as a pathogen in adults, compared with influenza and with SARS-CoV-2. Therefore, without a dedicated education effort, RSV vaccination has the potential to be deprioritized relative to these other vaccines. And the work group notes that safety and efficacy of co-administration of influenza, COVID-19, and RSV vaccines must be established. The next steps for the work group are to review grade of the evidence for the GSK and Pfizer investigational vaccines, review analyses on the cost effectiveness of vaccinating older adults against RSV, review evidence to recommendations for each investigational vaccine, and to determine final policy questions. The age threshold in the policy question will be informed by each of these pieces of evidence, as well as other considerations. With that, I'd like to thank my CDC colleagues who have contributed to this presentation through review and discussion, some of whom are named here. And I'd like to close with a few questions to our ACIP members. First, are there additional data needed prior to ACIP voting on recommendations for the use of either of these investigational vaccines in older adults? What additional data would ACIP like to see to determine an appropriate age threshold for an adult RSV vaccine recommendation? And are there additional questions that ACIP would like answered regarding an adult RSV vaccination program? And with that, thank you.
Thank you so much. I'm going to ask if there's any key questions people will want to see come back to a future meeting that are critical, because we need to move on to the pediatric section of the RSV vaccines. Ms. Bata.
As we think about the age threshold for recommendation, do we have, and this may have been presented in June, but racial and ethnic breakdown of RSV, because I think we need to be considering the equity aspect of this.
Great. Thank you. Dr. Paley? While you're thinking, I'm just going to, put in a generic plea that, well, welcome to pediatrics in terms of the complexity of the vaccination schedule. The second thing I'll just say is I really hope we can get to a place where we can get an age-based platform that is a lot more straightforward and really focuses on respiratory diseases sort of across the board. Having that data and actually some types of rates would be really helpful. So I'm looking at absolute numbers here and relative rates in another presentation. Having that consistency of that presentation would give me a better sense of the relative burden of these infections. And then on there, and see if Dr. Paling has any questions.
The other thing I wanted is if we could help so that we're using the same definition for like lower respiratory tract infection, because the number of symptoms is not really as important to me. And so if we could be able to compare across, that would be helpful to me. And then I would like to see the breakdown on the safety data by age.
Thank you.
Thank you. And while we're on safety data by age, I'll ask for background rates too as well. Anything else? Dr. Sanchez, thank you.
Thank you. I think some comment about enhancement of disease after vaccination is important. It doesn't appear to be, but I think we should be able to comment on that.
Thank you very much, Dr. Sanchez. Terrific. Thank you, Dr. Melgar. Thank you for that excellent session. It produced a lot of questions, and it was really great data. So we really appreciate how much progress has been made. We're going to move on to Dr. Long, who is going to present. She is chair of the Maternal Pediatric RSV Work Group, and she will present on the work group activities.
May I have the next slide, please? We have a very wonderful, large work group with many questions. It's not exactly pneumococcal vaccine, but the strategies and the policies are as complicated. Dr. Sanchez, Brooks, and Cotton are members of this work group, as well as many liaisons from other groups and from the Centers for Disease Control. So RSV is the leading cause of hospitalizations in U.S. infants. It can infect the small airways and lungs, particularly in infants, and in about 40% of infants who are infected, they will have lower respiratory tract disease. Most infants, or 2/3, are infected in the first year of life, and nearly all by the age of 2 years. Premature infants who are born less than 30 weeks gestation have hospitalizations that are 3 times higher than term infants, and their admission to intensive care unit and need for ventilation is also increased compared with term infants. 79% of children hospitalized with RSV, however, are under 2 years of age, have no underlying medical condition. So although we identify risk groups, we know that all children are in fact susceptible and are susceptible to lower respiratory tract disease and hospitalization. So it is the cause of hospitalization, most common cause of hospitalization is RSV for previously healthy term infants as well. In fact, 2 to 3% of infants who are born are hospitalized for RSV. So the burden of disease and the outcome, the severity of disease is significant. Next slide, please. Am I doing something? I'm sorry. Can you go back a slide? When we previously presented to this group, we presented the epidemiology and burden of RSV disease in infants, the seasonality that prior to the pandemic was very tight and repetitive, and now has become slightly different for the last 2 or 3 years, with our worst season and all of my colleagues, both early and more hospitalizations, stretching resources throughout the United States. We talked about the virology and immunology of infection, and we have talked about the safety and efficacy of nirsevimab. Now, since we've been talking about vaccines, everybody should realize that this is not a vaccine. This is an antibody passive protection. So the initial results of the pivotal phase 3 study in infants born nearer term, above 35 weeks and above, has been presented previously. The phase 2b study in infants born 29 to 34 weeks gestation who would have been candidates for palivizumab, and a phase 2-3 safety and pharmacokinetic study in high-risk infants with chronic lung disease and congenital heart disease. Now, the phase 3 study, the one on the top, was halted, went on hiatus in the middle of COVID because of lack of cases of RSV. So between 20 and 21, it was paused and began again in 21. So today we will have the results of the entire phase 3 study to evaluate. We also will have some second-year data on those phase 3 infants given nirsevimab in the first year of life, as well as phase 2-3 safety data on infants who have been given 2 doses. Next slide, please. So back one slide, please. The presentations today will first be from Sanofi, Dr. Christian Felter, and then from our very able work group leader at the CDC, Dr. Jefferson Jones, with comments by Meredith McMorrow. Thank you.
Thank you, Dr. Long. We'll move on to the presentation by Dr. Felter, if we can get his slides up.
Thank you very much. If you could stop sharing your screen and I can bring my slides up. Okay. Thank you very much. Hopefully, I'm just going to check. Are you able to hear me okay?
We can, but if you can step a little closer to the mic, that would be helpful.
No problem. Thank you very much. To introduce myself, my name is Dr. Christian Tillenfelter on behalf of Sanofi, and here with me I have Dr. Tanya Villafana and Dr. Amanda Leach representing AstraZeneca, and we're very pleased to be bringing you this update on nirsevimab for the prevention of RSV in all infants, and thank you, Dr. Long, for the introduction. Next slide, please. So we're going to go through two major portions of this presentation. The first part is going to be a brief background on the studies to set the stage, and then to focus on the new data that is coming from the ongoing clinical trials, as was discussed by Dr. Long. Thank you. Next slide.
Yeah, I got to end this because this is a waste of running. They'll probably resume this at 1 o'clock though, in just a very short time. But anyways, I have to end it. Y'all have a wonderful day. Thank you very much. Everyone that came in, blistering barnacles, squirrels magnet fishing, Halloween, everyone. Thank you. I appreciate y'all coming by. They went through a lot of the data, so-called data, before they do these votes today. So yeah, that's what it was all about, y'all. Thank you.